Good morning. Thank you so much for joining us today. My name is Marissa Weiss, and I'm a Product Marketing Manager for Jokes Lymphology. The topic is lymphedema versus edema for our webinar today. This will be presented by Carol Johnson. Carol is a CLT, LANA certified, OT, and a medical seamstress. She has over 40 years of experience and co-owned a lymphedema clinic. Additionally, she consulted in the creation of the Jovipac nighttime garment line to make it the success that it is today. Please note that this is a recorded session, so we will not be taking questions at the end. However, feel free to send me any questions and I will help get them answered. Without further ado, I will pass it over to Carol.
Good morning, everyone, or good afternoon. Thank you so much for joining me today. I am very interested in helping people understand the differences between edema and lymphedema. We see these differences in patients when they arrive in our clinics and in our fitting rooms, and it is important for us to understand the differences so that we can treat them correctly and to provide the patient with the most effective management system that's out there. So without further ado, let's just move on. What I'd like to talk about here first is to talk about the blood circulatory system and how it interacts with the lymphatics. The blood circulatory system we all know about. It is the system that is being managed basically by the pump of our heart. We pump blood to the tissues in our body through the arteries, and then it is the debris and excess fluid is carried then away from the tissues via the veins. They return, the veins are going to return the deoxygenated blood to the heart and the lungs where it can be purified and cleaned again. And of course, the arteries are the vessels that are coming from the heart and moving that good, fresh, oxygenated and high nutrient blood to our tissues. The tiny capillaries are the little leaky vessels that are between the veins and the arteries, and this is where they're going to exchange the oxygen and the nutrients for the tissues to use, the cells to use. And then as the cells have normal respiration, they excrete a type of toxin that needs to be returned to the through the veins. And also, there is another blood circulatory system, actually not a blood circulatory system, but a system that is of what we call our lymphatics. And that is the system that's going to also return excess fluid and toxic materials back into the blood circulatory system, but not via the veins. So in this depiction you'll see of this drawing, you'll see that there's sort of a yellow background, and those are our tissues, and that's where all the cells lie. And you'll see individual cells here that have the nucleus in the center. The spaces between those cells are the areas actually where we have excess fluid or fluid that is normally there bathing the tissues so that the cell, so that it can have an avenue of transportation for that toxic materials to be returned back through the lymphatics. The blue vessels are going to be the veins or the venules, and the red ones, of course, are the arteries or the arterial. And as it gets into this tiny little tissue bed or the lymphatic bed, you'll see that it gets smaller and smaller and changes from red to blue. Mixed in between all of this, you see these green little blind end capillaries, and those are called the lymphatics. And the lymphatic capillary has a little opening at the end of it so that as tissue pressures change in that tissue bed, those little valves, if you will open and close and allow fluid to move into them and then be moving on to the rest of the lymphatic system. So from here, then we move on to the lymph capillaries, and they are going to contract about 3 to 10 times per minute. These can be stimulated to contract more frequently with a special massage technique we call manual lymph drainage, and we're going to talk about that a little bit in the preceding slides. And it's a type of a massage technique, but also it moves just by normal muscle contraction. So when we are moving our muscles, just the muscle pump is what helps move it along as well. It does not have its own pump like the heart. The lymph capillaries are divided into segments, and they have one-way valves, and they are preventing a backflow, and these little segments are called lymphangions. Each segment contracts independently of the others, and when it's stretched to its capacity, then the little stretch receptors in the walls of that vessel will contract, pushing the fluid to the next angion. And if any of you know about peristalsis, this is basically this process of peristalsis. Also, if you look at the drawing on the right of the lymph capillary, you'll see here that some of these little endothelial cell flaps will open, allow that fluid to move into the vessel and move on beyond those valves. And the anchoring filaments that are here are actually connected to other connective tissue as well. Fluid dynamics, I'm not going to go into this too deeply, although it's just important to realize that our bodies and a normal adult will move approximately 2 to 3 liters of fluid per day through that lymphatic system. There is a lot of fluid available in that space between the cells, and that's called interstitial space. And it occurs, of course, as a result of the filtration of the fluid through those leaky capillaries. That interstitial fluid then moves around the interstitium by that system under normal conditions, and it should be moving through the lymph vessels without any interruption. And it is their job of the lymphatics to move proteins, fats, plasma, cellular debris, and excess water. And if there is a problem in any of the lymphatic system, it is a problem for the lymphatics, and some of these things get left behind. Under normal conditions, the lymph nodes are the filter organ for the lymphatic system, and there are approximately 1,000 lymph nodes throughout our body, and the vast majority of them are around the head and the neck. This is where we take in many toxins through our breathing and through our eating. Regional lymph nodes are found in the neck, the axilla, the groin, or the inguinal area of right above the top of the leg as it joins the body, the paraspinals between the ribs and in the back, the parasternals in the breastbone at the front of our body, and throughout the intestinal tract. Within the lymph nodes, we have immune cells, and these are considered our soldiers. These are our working cells, and they are basically an army to get rid of that foreign material that is transported from the cell into the lymphatics, and then it starts to devour those. And these can be dangerous substances. Some of them are bacteria, some of them are viruses, some of them are actually cancer cells. And these, again, are all produced by the lymphatic system at the lymph nodes. The edema, then, let's just talk about that portion of it, is the system or is the condition that occurs when we see an excess amount of swelling. And formerly it was called hydropsy or dropsy, and it is actually an abnormal or an excess accumulation of fluid. Inside that interstitium, or in between the cells, that interstitial space, and it gets filled up with fluid, and it's clinically explained as being a swelling. The interstitium refers, of course, to that space, and this is where the body then is able to transport that extra cellular debris, extra water, and where some of the metabolism actually occurs. Generally, the balance is homeostatic, which allows for there to be a nice balance, and the normal interstitial fluid should move in and out, and it should be able to maintain this level of homeostasis. But when it's impaired, removal of all of that extra secretion and extra fluid causes edema. And this is where we come into many different types of edema or swelling. Edemas are graded generally depending on the depth and the duration of the displacement of interstitial fluid when an external pressure is applied. So for instance, if we were to take our index finger and push it into the tissue, we would end up with something that looks like a pitting edema. Cutaneous edema occurs when a small area gets pressurized and an indentation occurs. And after the pressure is removed, we see this indentation, and we often will see it during airline travel or while at high elevations we might have trouble getting rings off and that sort of thing, and our hands might feel swollen. Peripheral pitting edema is a common type which occurs when there is a retention of fluid, and it's caused usually by heart failure, when the heart is not pumping well enough, pregnancy, when there's a lot of pressure on the vessels of the legs, or other diseases, and it's most notable in the lower extremities. We often will see in lymphedema condition called non-pitting edema, and that's where the indentation is not persistent, and usually the skin and the tissue is quite hard. And we see it in things like myxedema, lipedema, and lymphedema. These pitting edemas are graded, and there are numerous ways to do that, and I'm going to just explain how these work. It's graded on a scale of 1 to 4, and there are numerous scales out there, so I'm just going to go through some of them. The scaling depends on the depth of the pit that it leaves in the skin, so it can be a 1+ pitting edema. You might see even in some of the information that you get from your doctors that it is a 3+ pitting edema, and that just means that it's about 6 millimeters deep when they put their finger into it over a period of time, or maybe it's a 4+, which would be 8 millimeters in that grading system that they're using. Another method is the depth and the duration. So they will use a grade 1, 2, 3, 4, and basically that's what we just described. And it usually lasts for up to 2 to 5 minutes once they put a big dent in the limb. So if it's a 4+ pitting edema, we could say that it's about 6 to 8 millimeters deep, and it might last as much as 5 minutes, and it's depending on the way the extremity is distorted when that edema is displaced, or when that fluid is moved from that space in the interstitium. Usually grade 1, grade 2, we often see in many patients with different kinds of edemas, but it's these 3s and 4s that we get really concerned about as to what's causing it. The dent depth and rebound time is another one that they talk about, and it can be up to, usually if it's a grade 1, we'll see an immediate rebound and you won't see really much of an indentation left for very long. But if it's a grade 3, it might last 10 to 12 seconds, or 4 plus it's going to last greater than 20 seconds up to 5 minutes, of course. So you can see that these are all pretty subjective, and just depends on the person who is making that determination. So as you become more adjusted to using these different kinds of scales, you might even investigate this even a little bit more. This one is not commonly used in the United States, but in Europe they do use this occasionally, and they use it as a 3-grade scale using bilateral pitting, and when it's not present, the grade is just called absent. Bilateral pitting edema grades are classified using plus signs. So usually if it's pretty severe, they have generalized it to being in both limbs, and it could include both legs, both arms, the feet, and the face. But the classic one that we use is, as I described earlier, we have the latent, what we call latent, where you actually have difficulty seeing it, and the patient may not even be aware that it is there. And usually we see these on LDEX machines that can detect the amount of edema in the tissue. So 1 plus is barely detectable. 2 plus, there's a slight indentation when the skin is depressed and it remains following for a small amount of time. 3 and 4 have a deeper fingerprint, and it can return sometime within 30 seconds to 5 minutes. And the extremity can be, if it's a 4 plus, can be 1.5 to 2 times its normal size. So these are pretty severe edemas that we see with this kind of a patient. There are so many different kinds of edemas that we see out there, and it's just important to recognize that not all kinds of edemas need compression. So a general possible cause of localized swelling would be a traumatic injury, for instance. That it might be infected, you might see an infection, you might see some kind of skin swelling, but any edema that is treated with compression is going to show up here in the pink. So dependent edema means that the edema that you see maybe in the lower portion of the limb as a result of gravity pulling that there. So that kind of edema is very appropriate to be treated with compression. Lymphatic obstruction, we certainly see that, and we would see that in some types of surgical procedures, radiation, and so on. Venous thrombosis, we can treat this with compression, usually after 3 months is often something people will say, but there are other therapists and physicians out there who say, well, as soon as the patient can tolerate the compression, let's put them in it. There has always been a concern that you might mobilize a thrombus or a clot in the leg, and that would be an indication to maybe, if it's unstable, to ask the physician if it's okay to put them in compression. Venous insufficiency, certainly when the veins are not efficiently taking the fluid away from the area, then we can see an increased amount of, or an increased volume of fluid in the interstitium as a result of the veins not working properly. Some possible other conditions that cause skin swelling, of course, would be trauma, skin trauma, maybe a scrape, maybe an infection. Cellulitis certainly is one of those, an infection, a bacterial infection. Contact dermatitis, eczema, hives, allergic reactions, insect bites, insect stings. These are all types of swelling that you see. They tend to be fairly localized and generally should not be treated with compression. Drugs can cause generalized swelling. That might be something that would be considered, or if the doctor would like to put a patient in compression. That might be an indication to help the patient feel better. It will not, however, of course, get rid of the swelling until the drug or medication is stopped. Pregnancy is a very common type of condition that we see, and that's because of the pressure on the veins coming from the legs. Preeclampsia is a condition that causes high blood pressure and can be an emergency. So those are things that probably should not go into compression but need to be seen immediately by a medical facility. Premenstrual syndrome, heart failure. Now, congestive heart failure can be treated with compression, but should be used only with the blessings of the physician and should be discussed with the physician as to how much compression the patient should have. If it's untreated, I'd be very cautious, of course, before compression should go on that. Some kidney conditions are not going to be indicated for compression. However, some kidney transplant might be. Nephritis, glomerulonephritis, nephrotic syndrome, kidney failure, liver conditions. Many times that's just not something. Kidney and liver is not going to be very receptive to compression, but again, liver transplant may be. So any of these that are in hot pink might be an indication for compression. Now let's go on to what lymphedema is. This is a condition that results from an impaired flow of the lymphatic system. Either there's a problem with the lymph vessels in one way or another, or there might not be enough. Their vessels might be too small and can occur at different times. Lymphedema is always a high protein edema, and that just means that because of the problem with the lymph system, the protein that is in the tissue at the cellular level is actually left behind because it is only the lymphatics that will move protein. And unfortunately, protein is a magnet for water. And so the more protein that's left behind in the tissue, the higher amount of water that gets accumulated and stored then, if you will, in that interstitium around the cells. All the symptoms that we see in lymphedema, of course, are going to be swelling in one or more of the extremities, and it may range from mild to severe. And of course, this can be quite disfiguring when the lymphatic system is broken in one way or another. A person may not even recognize that they're swelling if they have this latent phase where they really can't see it. But patients will often say they can feel it. They often feel that it's heavy, and they may say that their range of motion in maybe a limb, like the elbow or behind the knee, feels full. We may not be able to see it, and we may not be able to measure it, but the patient can feel it. There are two kinds of lymphedema basically that we think about. Is it a primary or is it a secondary? Primary lymphedema is present at birth, and it may not be noticeable, and we may not see it, and it may not develop until someone might be into their 30s, but it may even be present at birth. I have had many patients in my infants in my clinic actually were born with a swollen limb, and other times I've had patients show up in their 30s and 40s and say, I don't know what happened, but I woke up one morning and my leg never got better. And so we would consider those to be primary lymphedemas, that they have a propensity for swelling. Something has gone wrong with the lymphatic system at one point in their life. Secondary lymphedemas are acquired, and it's a result of some type of damage to the lymphatic system and causes this disruption in the lymph system to be able to flow all the way through the lymph nodes and the lymph vessels before it goes back to the heart. Now you'll notice here that this drawing that there is in the body, there's a left and a right side. The lymph nodes that we see, regional lymph nodes, we see generally in the inguinal lymph nodes at the groin. We see a large accumulation of them at the axilla and along the sternum and along the spine in the back and along the intercostals and all through the mesentery of the gut. And we can see symptoms of lymphedema can occur in a leg or an arm at any given point for primary lymphedema, and secondary lymphedema can occur after some type of an injury. We often see it in cancer. We see it in joint replacements such as the knee. We can see it in major surgeries of one sort or another. Lymphatic circulation is going to be divided basically. If you look at this drawing again, you see that there's red lines, that there's a division right down the middle of the body and one right across the waist. Regional lymph nodes, as I described earlier, are in the axilla and the lymph and the axillary lymph nodes and the inguinal lymph nodes. I'm sorry. There's a lot of lymph nodes in around the neck as well. And the lymphocytes are in the lymph nodes in these regional, where these regional lymph nodes reside to help with our immunity. The vessels, lymph vessels are both superficial and deep. The superficial lymphatics are found just under the skin, between the skin and the muscle. And the deep lymphatics are deep in the body, and they carry a large amount of lymph back to the heart. And the body is divided between the left and the right, and there are 3 areas of the body that are drained by the left lymphatic vessel. It runs right in front of the spine, the 2 legs, and the left upper body. So the arm, the chest, the abdomen, and the 2 legs are drained by the left lymphatic. And the right lymphatic vessel is found in the right chest, and it carries lymph from the right upper quadrant to the area right at the heart, where it's going to drain into the blood circulatory system and become plasma. And I hope at this point that there is a light bulb that has gone off. So all that fluid that's coming from the cellular level is transported back to the heart via these lymphatics, and it drains into the blood circulatory system and becomes that yellowish fluid or that plasma in our body. So once a patient has been diagnosed with having lymphedema, it's important that a physician or a qualified lymphedema therapist determines the current stage and what is the chronic condition that this patient has and what might their prognosis be. The sooner it's identified then to get treatment started, the better chances of that patient's prognosis. The International Society of Lymphology, or ISL, has established a staging system to identify how this condition progresses and how severe it may be or how severe it can become. And this will help us determine what our success and what kind of improvement we can provide for the patient. The staging applies to the limbs, to the arms, and to the legs only. And it's based on the swelling. And as we described earlier, those different levels of pitting edema are going to be applicable here too. So when there is an improvement and an understanding of the lymphedema, the patient actually can gain the best benefit. It gives them some control for their edema, and so education is vitally important for this population. And we added a 4th stage, is being currently used by ISL, and it consists basically of numbers being from 0 to 3. So 0 being that latent stage, 1, 2, and 3, then add that 4th one. So if you'll go back to the staging as we described earlier, or listen here, stage 1 is that latent preclinical stage. A patient often can feel it, but we can't measure it unless we get it on an LDEX staging, which can be very helpful. And we're very lucky because now at this point in our evolution of treating lymphedema, this is available to many many people. Studies have indicated that through the use of bioimpedance, which is these LDEX, it's possible to see the changes and what the risk of those limbs can be. And when changes develop, if these specialized treatments are started immediately, we can prevent it from progressing onto the next stages. So it's a non-invasive procedure, and if your hospitals or someone in a major teaching hospital has one, it would be wonderful if your patients could actually go there. Measurements have been studied to establish a baseline at the time of breast cancer treatment. So if we can get our breast cancer patients into these machines and have that measured right away, we can see if they are actually progressing. Stage 1 is the accumulation of fluid, and of course it's a very high protein edema, and it's visible, and it is visible by pushing on the skin and causing a pitting edema. Sometimes with stage 1, and generally when the limb is elevated, it can be resolved, and we call this a resolution of the edema. So stage 1 is where you would like to, either latent or stage 1 is where you want to keep your patient, is if we can. It should then go through a lymphedema therapist, get the edema managed as best as possible, and then compression put on that patient. So it should be usually a mild compression. Stage 1 should go often usually go into a grade 1 garment. This is what stage 1 lymphedema may look like. It really maintains most of the normal contour. It's just a little bit fuller and heavier in the way it feels and looks. Stage 2 is where we're beginning to get fibrosis, which is a formation of a scar-like structures in the tissue. The fibrin is beginning to throw out into the area around all of that high protein edema to wall it off. It is recognized as foreign at that high concentration. So the tissue becomes more firm, and this is what we're trying to avoid with patients at all cost. Pressure against the limb will produce only a slight indentation and maybe no indentation at all. And this is where we might go to a higher compression with our patient, depending on how quickly or at what level of in stage 2 that we get them. Early stage 2 lymphedema, we can see a deep indentation after a long period of time, and you can feel a hardness in the tissue. The patient can feel it as well. Stage 3 lymphedema is considered elephantiasis. This is where we see a lymphostatic elephantiasis, lymphostatic disease, where there is the lymph stasis. The lymph becomes stagnant and it becomes more like a hardness in the tissue, and it doesn't move very well. It becomes more like a real hard gel rather than a fluid. We should normally feel the tissue should be able to mobilize fluid much easier, so you will feel this heavy, hard fibrotic tissue. And the skin often will have skin changes, and it might change in color. The skin may have no more elasticity in it. You might see skin hanging in folds. People can develop something called papillomas, where small benign tumors or fluid-filled tumors project around the tissue. And hyperkeratosis is an increase in the thickness of the outer layer of the skin. And we see this because there's just poor nutrition to that tissue. So elephantiasis is at the latest stages, and this is the most difficult to treat. Changes in the texture of the skin can be quite disfiguring and will limit their patient's mobility. Infections are very common because high protein edema is the perfect medium for bacteria to grow. Any break in the skin can cause an infection. These infections can be fungal, or they can be bacterial, and they can often form within the skin fold. With intense therapy, stage 3 can be improved, and but most importantly, is potentially preventable. And so we want to make sure that we get it as early as possible. Rarely is this one ever reversed. Surgical debulking is a treatment that's sometimes used to reduce the size of the limb. Healing from the surgery can be difficult, and because the skin is still hardened, it still hangs in folds. So deep creases are present, and the skin remains at risk for infection and open wounds. So both of these pictures are stage 3. The picture here in the middle is of one area that has been deflated. Basically, this was a large lymphedema and it was deflated, but the skin remains in heavy folds, and this patient still is at risk, although is a bit more mobile. Stage 3 lymphedema, this is actually a lipolymphedema, where the patient actually had developed a condition called lipedema as they got older. It's a fat disorder, but because of so much adipose tissue that was left in the tissue, they developed lymphedema as well. So the prevalence of lymphedema in the world is approximately 3 million people having lymphedema, and 124,000 people have cancer-related lymphedemas in the U.S. The breast cancer is one of the largest, or is the most common cause of lymphedema in the U.S. That is a secondary. And then lymph node dissection and radiation, of course, is what is causing that. So 20 to 40% of the breast cancer patients are going to develop lymphedema. Filariasis is something we don't see in this country. It is the most common cause of lymphedema in the world, and it's generally it is spread by black flies and mosquitoes that occupy the lymphatic vessels and lymph nodes. So those little parasites get in and block the vessels, so the lymph can't flow through the lymphatic system any longer. There's no cure for lymphedema. Manual lymph drainage, or MLD, combined with combined decongestive therapy, or CDT, is an important part of the treatment. We combine different modalities to complete the treatment, and they go through 2 phases. One is phase 1, where they have a reduction before they are fit in compression. And the compression treatment is effective in reducing the swelling and discomfort once they've had manual lymph drainage. There is a condition of edema called idiopathic edema, and the body usually starts to retain salt for no known reason, and it causes the blood vessels to leak fluid out into that interstitial space. That amount of swelling can fluctuate over time, and patients can experience this feeling of heaviness without any actual physical signs of edema. But it's not unlike lymphedema, but this is not a high protein edema. This is not where the protein is leaking out and being stuck because the lymphatics are not working properly. It is really a condition of a salt discrepancy in the tissue. Dependent edema is something that is also not a high protein edema. This is something that causes an abnormal accumulation of fluid in the dependent parts of the body due to gravity. Sometimes we see our geriatric patients or our elderly population sitting in wheelchairs for a long period of time, and they have this dependent edema. Or if we have a job where we're standing for a lot and not really moving our muscles very well, maybe we're standing at a desk and not moving around very much, we can get some swelling in the dependent portions of our feet. Sometimes we get it with air flight when traveling. Extremes can be managed with gradient compression and or even short stretch bandages. But this, again, is not a high protein edema. Once the limb is elevated and the person is out of this condition where the gravity is pulling, then that edema resolves. Deep vein thrombosis versus post-thrombotic syndrome. You probably think these are that they can be used what's the word I want to be used differently, but they really are very different. A DVT is actually an active blood clot, and this is extremely serious. This can lead to a pulmonary embolus, where these can break off, travel through the vein, and end up in the lung and or the heart and or the brain. A post-thrombotic syndrome is a result of a DVT, and it's caused damage to the vein and the surrounding tissue, and it may include ulceration in the lower leg. So it's going to occur in about 40% of those that have a DVT, and it can severely impair a person's ability to manage that that wound, and it can vary from person to person. Some of these DVTs are some of these post-thrombotic ulcerations can take a long time to heal. And when is compression recommended for this condition? With a DVT, it can improve pain and swelling. Theoretically, it's important to consult the physician before fitting a patient and issuing a stocking to make sure that it's not an unstable clot. If it's active, it could theoretically move. So it's really important that the physician be the guiding force here. Post-thrombotic syndrome, compression can improve the symptoms of pain and swelling, and can, of course, improve swelling, can improve pain, pressure, heaviness, tightness in the leg, if the legs are tired, even some of the hardening or itching that a patient may be feeling. Some of the dark pigmentation that develops, visible spider veins, ulcerations can be easily treated with a mild compression over it. So these post-thrombotic syndromes are certainly indicative of using compression on them. There's a condition called mixed edema, and you may have seen this before. This is where the limb may swell and the underlying tissue gives sort of this waxy consistency, and it's typical with patients who have an active thyroid. This is not a high protein edema, and it's generally not something that's going to respond very well to compression unless it is to treat symptoms of discomfort. So patients should be referred back if this is your consideration, that you think that they may have a high protein or have a mixed edema. There is another condition called ascites, and this is an accumulation of fluid, and it's a serous fluid usually found in the abdomen or the peritoneal cavity, and this is, again, is not a high protein edema. We would have no benefit to put this patient in any kind of compression and would probably cause the patient great discomfort. So anyone who has ascites should not be treated with any kind of binder or compression around the abdomen. So I'd like to reiterate and give you what I feel is the takeaway message for this presentation, and that is that treatment for swelling is totally dependent on the cause. Is it congestive heart failure? Is it a vascular problem? Is it a true lymphatic problem? Using a system to identify the swelling is going to indicate the kind of swelling and therefore what kind of compression might be indicated. Some swelling conditions are best treated with compression, but not all of them. Lymphedema, again, is a high protein edema, and it requires 2 phases of treatment. Phase 1, the initial phase being the intensive to get the reduction before they are fit with compression, and stage 2 is compression is the maintenance phase that they will stay in for the remainder of their life. So I'd like to thank you for your attendance to this webinar. Again, if you have questions, please reach out to Marissa at Jobst Essity, and she would be happy to get to one of us to help answer those questions. I hope this was helpful. Thank you.